paper exam on the Wednesday, right? Okay. And it's going. Yeah, it's the med one is actually med one is supposed to be supposed to be the whenever what I learned from med school is this, like whenever you say like whenever they say a basic or introduction or kind of the whenever they say like something like a very kind of the very primitive things, right? Or elementary, those are very very hard usually. Rather if you go like the down the road, and then if you uh just more specialized in some systems, things becomes easier. Okay, so by the way, I uploaded the PPT, so you can just download it. In the meantime, I'm gonna share my screen. Just a minute. Where is my share? Oh, share the screen. Screen. Okay, do you see my screen? So, um, when you feel that, oh, this is supposed to be basic things, but it's don't get tripped on it. It's basic is the hardest one. Okay, basic or introductory things or like primitive, the elementary things. Those are like the hardest thing. So don't get tripped on that. Okay, oh my God, I'm having hard time in the basic. How can I do more advanced stuff? No, it's not. It's not really true. So more advanced stuff is easier. So first, basically, when you this like you had first you have four cases, right? Case one, case two is foundations and those things. Those are kind of especially in the foundation is the hardest one. Okay, then when you become the like musculoskeletal and the GI and this one, right? So those are the ones that have maybe one third of the your the systems of the each of the systems. Like what I'm saying is like the neuro, in terms of neuro, you just finished the only like one third of the neuro. Okay, and then the other two third will be learned in the med three for neuro, and then med three, med four basically complete the all the systems uh, in its full contents. So med one, med two, med one say basically learns like med one and med two learns only you learn only like the anatomy and the physiology. But med three, med four is like a real thing basically. You learn pathology and the pharmacology, microbiology, those are like really high. So, what I recommend you to do before you start Med 2 during the break, although I know you don't have a like long break, but here's what I recommend you to do. I write it down in here. uh, do you know Sketchy? Sketch Micro? Here's the things that are the you will be the beneficial. It will be beneficial to the during the break. Okay, so break during the break. Just watch the sketch micro as if you are the listening to the music. Okay, just turn it on and then keep watching what the playing. Just you don't have to like write it down everything, every detail. You just watching it just to get get yourself to be familiar with that the microbiology. Okay, so sketch micro basically is the like a bone. How can I say bare bone. This is like a bare bone of the micro. Okay, so that's one thing. And then Pesoma. Pesoma is the it's a real thing. It will be really helpful for you to digest materials in Med 2 and Med 3, Med 4. Okay, so it will build the basis for the Pesoma. So I mean the future systems. So I want you to uh, watch the chapter 1 through chapter 5 only. It's like the 19 chapters, but the other ones you can just watch it later. But those ones, watch it I mean, during the break, you just watch it. It's not just to listen to it, but you gotta sit down and then annotate and all these things. Okay, so this one, you gotta focus on this one. This one is just you just watch it as if you listen to the music, right? So by just doing this two, and then if you have some time left, then you can watch Bode and Beyond. Bode and Beyond is a very uh, kind of comprehensive the say medical subject. Okay, so it covers the like broad topics of the all topics of the medical schools. So which is good. Or I mean, you can watch it like whatever you wanna, whatever source is available to you. RX is good. Also boot camp. Boot camp is like a kind of new kid in the block. Okay, so this is very new. But in terms of the question bank, I wouldn't recommend this boot camp very much because what happens is this is kind of their the Q banks are just brand new, so it's not very refined. Okay, so for instance, if you have a kind of the Q banks that has been in the market for a long time, like UWorld has been in the market for a long time, many years, and then their questions are being revised and revised many times. So if you look at the questions from the UWorld, that there's like the last revision date, and then it's very the new. It's like almost like 2000. Most of them is like 2023. So the reason being is that it's not because of the questions were being made in the 2003. It was made long time ago, and then it was being revised many times. Okay, so you will rarely find some mistakes, and then the questions are very trendy. What I'm saying is like it's very conform with the real step exams. Okay, so UWorld is highly recommended for the QBank. And then the RX is also good because it's been in the market. But in terms of a QBank, I wouldn't recommend that much in the boot camp. Although the materials in the boot camp is really good. Okay, so that's what I'm saying. Okay, all right. So sketchy, just watch. A few times, just continuously. Keep playing and in the background while you're driving, while you're taking shower. No, not a problem. Okay, but Pesoma, you have to sit down and then watch chapter 1 through chapter 5 only. Okay, and then if we have a more extra time, then spend more time in Body and Beyond, and then RX or the boot camp. Either way, up to you, right? But in terms of question bank, and then UWorld or the RX is the main thing. Okay. The another caveat that I wanna tell you is that when you go to the probably the some of your professors, even professors will say that, oh yeah, don't try the UWorld at this time of the stage. That's not really true. You are already late if you don't the subscribe for UWorld. You're already like 6 months late. Seriously, you have to start from day one of the medical school. Okay, so UWorld is a really good source for medical school, and because that's how the real exam will be. Okay, so of course at this stage you will see that, oh, I got like 15%. out of the 100% for this block. Doesn't matter. It's not scoring what you learn, what you know. It's just a basically learning tool. Okay, so just keep doing again and again, and then you will eventually get high scores there. Okay, so that's what I'm recommending. Okay, so let's start this business here. So what I'm gonna do is I'm gonna this is the questions. So I will I don't wanna use like some if there's a like some polls or something like that. But why don't you just the like if you can the write down in the chat the answers in the I give you maybe the 45 second or 1 minute, but I don't want to spend too much time it's the for you to just you know wasting of time and reading this. Okay, so just the write down the whenever you the I don't really care, so it will the maybe the distract others, but just write down so I can explain more time. I mean, I like to spend more time in explaining and then interact with you rather than just wait, for 1 minute and doing nothing. Okay, all right. So yeah, so time start. So you can whenever you have an answer, so you can write it down on the chat so we can discuss. Okay. By the way, all these questions are from UWorld. So like I said, UWorld questions are probably the hardest to QBanks. Okay, so don't get discouraged. Oh my God, I have no idea what the question is talking about. Don't worry. Okay, so that's what everybody feels. UWorld is a learning tool, not testing you how much you know. Okay, right. In the meantime, I will highlight the keyword in here. Okay. What do you think? You can just the write down on the chat. This will be this type of question will be in the exam for sure. Very, very. You already learned these questions already. What do you think? E. I said him section. Yes. So what's the name of this the condition? E is correct. Yes. What's the name of this condition? Yes, yes, that's correct. Okay, so this is Brown-Sequard syndrome. It's very favorable topic for the exam purpose. Okay, clinically you will never see this kind of the symptoms, real symptoms, but you will see that every exam basically every exam will have the Brown-Sequard the syndromes. Okay, it's very very popular topic because the professors are usually very lazy, and then this is very lazy. The more lazier the professor is, the probably more chance to for him to make this kind of questions because so easy. Brown sequence is like super easy questions. You don't professor don't have to think about it because but but it will at the same time it will test to you all kind of concepts in here. Okay, all right. So this is the Brown sequence syndrome. Okay, so I like to at this time I like to go to the other. Let me see. We discussed about the. Let me see if I have also same. Maybe here. Just a minute. Let me find out where the. We discussed about the pathways, right? So let me just add one more thing on the pathways. So I'll just write in here. Okay. Why don't I do this? So basically, when you think about the pathways, you just think about these three pieces. Okay, don't get don't think. I told you that don't think like it goes like down as the from the lateral side, and then it goes to medial and that kind of thing. Just forget that. Okay, make it simple. So let me do this. Okay, why don't I just do this? Right. So the reason that this is that I'm spending more time on this is because this will be on the exam, and then this is super important. And if you understand this, so this is the cortex, okay, and then this is the brainstem, and then this the spinal cord, okay. So what am I drawing? This is like this is say a sensory, okay. So what am I drawing here? This is coming from here, and the this is I let me just hint to you, okay? Dorsal column, yes. Dorsal column, okay. And then the second neuron, okay? Second neuron, or in the sensory, second neuron will be tecosate, always. That's the key. Cross, cross, okay? So first neuron comes in here, and then second neuron, it will be uh, it just going here, and then in the here in the caudal medulla, which is the bottom of the medulla. Okay, so it'll the synapse in the second the caudal medulla, and then second neuron goes here, and then it thalamus, and then goes up. Okay, so that's the third neuron. Okay, so second neuron always decussate. Okay, I mean crosses. Yeah, crossing means decussate. Okay, all right. So this is a dorsal column. So let me see. Dorsal column here. Okay. Now I use the another color for uh, this one, and then here, and then goes up. What am I drawing here? And then let me highlight the second neuron with different colors. So this is the second neuron, right? Then third neuron is in here. Okay. What did I draw? ALS. Yes. Spinal thalamic tract, right? So basically, this is the detecting your the pain and temperature sensation, right? Dorsal column, spinal thalamic. So when I write spinal thalamic, the pain and temperature, they basically the same thing. Dorsal column, medial lemniscus, and the MVP, those are all same thing. Okay. And then this one has like the anterior and the lateral spinal thalamic tract. They are basically practically same, but if you go very in detail, this one anterior the spinal thalamic is usually it's like pain and temperature, right? For both, you can just memorize it that way. But if you wanna go one step further, this one no pain, but I mean no pain, but the crude touch and then temperature. Okay, but if you don't have any other space in the brain, then you can just assume do the same thing for the pain and temperature. Okay, so theoretically, this one has the anterior spinal thalamic causes only crude touch and temperature, not pain. Okay, so don't get don't get confused. If you don't get confused, then just forget about this what I just said. Okay, all right. Another that's two are the pathways, sensory pathways. Okay, how about the motor pathways? So the coming down here and then here. So here. Okay, so sorry, yeah, sorry. This is wrong. So coming down here and then here and then here. Okay, so the corticospinal tract, right? This is motor. Corticospinal tract has so motor neuron, two neuron systems. Sensory three neuron systems. Sensory, second neuron will cross. Motor neuron, is crossing, and then the two neuron systems. So low motor neuron, low motor neuron, LMS, low motor neuron, and then upper motor neuron is different because the upper motor neuron is CNS. Low motor neuron is going to be the PNS. Okay, so make sure this this one. Low motor neuron, PNS. Another name for this one is alpha motor neuron. It's the same as low motor neuron. Okay, same thing. All right. So I will add one more to complete, and because you know this one. So another best way here is a cranial lobe. Okay, coming down here, and it does not even touch the medulla. It will just here, here, here. Okay, this is a cranial lobe. Okay, cranial lobe has a two the neuron systems here, 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 and then here, right? So cranial lobe is cranial lobe the part of the CNS or PNS? Cranial lobe, listen very carefully. Cranial lobe is a PNS. There's a one exception, but I don't think they will test you for this because one only exception. If you again, if you don't have any memory space, you don't have to know this. There's only one exception, minor exception. Cranial 11 has accessory nerve, has a spinal pathway that briefly touches the spinal cord section and then comes out. But forget that. That's the only exception, but that's not rare. I mean, that's very, very minor effect. The exception. I don't think they will test on this one. Okay. So cranial lump. All you need to know is cranial lump comes out of the spinal. I mean, out of the brainstem, directly from out of the brainstem. Okay. So cranial lump is divided by three pieces, three groups. First group, midbrain. Second group, pons. And then third group, medulla. Okay. So that group, those the 4, 1 through 4, 5 through 8, the 9 through 12. Okay. Middle part, the part of the because the spinal cord is like this, right? I mean, brainstem is like this, right? And then middle part, and then there's some other lateral part, right? Middle part is divisible by when the numbers are divisible by 12, meaning that 4, 6, 3, 4, 6, 12. Those are divisible by 12. So 3 is divisible by 12, 4 is divisible by 12, 6 is divisible by 12. Okay, no 5, 7, 8, 9, 10, 11. Those are not divisible by 12. Okay, so this will be in the middle. 3, 4, and then 6, 12. Okay. And then if it's not divisible by 12, it's not in the midline. It will be in the side. So lateral part. Okay. So just by knowing this, it will make a big difference. Because for instance, in the medulla, if there's if the question was asking you, some patient has some kind of vision problems. If there's a lesion in the medulla, then there's no such thing as like your vision will be perfectly fine. Vision is occurring in here. You have oculomotor neurons, and then the all cranial nerves. Something to do with the vision is already in here, not in medulla. Okay. If we have in vice versa, conversely, say if we have vision problems, it's not going to be in the medulla. Okay. So something by just knowing this the rule of 4, you can just already maybe halfway the done with the questions, right? So the rule of 4 is very, very important, and then it will just help you a lot. A lot. It give you a lot of advantage to solving questions. Okay, so now the question is, where is the region? Okay, so if you have a region in so basically I want you to take the let me just clean up a little bit. Okay, clean up this one. I want you to take this picture. This is a very, very important picture. Okay, so I just yeah, this one, clean this up. This screenshot this one, because of this, just when first 15 minutes, you just screenshot this, and then it will be super easy for you to solve the questions. Okay, for instance, if I have a region, so this is the right side and then left side. Okay, if I had a region right here at the spinal cord level on the right side, what will be impacted? So you will be impacted. So whatever is in the this graph diagram here, so you will be impacted pain and temperature only, spinal thalamic tract. You will not be impacted on the dorsal column. So MBP is okay, and then the spinal the corticospinal tract is okay. Okay, all cranial lobe is okay. Only if it's the region in the right side of the spinal cord, then only spinal thalamic tract, pain and temperature will be affected. Okay, very, very important. Okay, so knowing this, so right side, the spinal cord, pain and temperature only, only. Okay, so how about right side, the brainstem? So if you have an impact a region in here, what's going to be affected? Is the oh, let me see. Oh, I just made a big mistake in here. Sorry about this. This one, this one. Oh, this one. Sorry. Yeah, this is the correct number. Just a minute. So this is the correct yeah, this is the correct the graph diagram. Okay. So if we have a cut in here, if you have a region in the right side of brainstem, okay, then what will be affected? Just follow this diagram. So you have because the right side is affected. So let me use it the different color here, right? So then the right all three of them are affected, right? So the what is it? The pain and temperature sensation in the opposite side, right? Pain and temperature affected, and then the MBP affected, and the corticospinal tract affected. But pain and temperature is the same side or opposite side? Is it pain and temperature sensation opposite side, right? Opposite side. So contralateral side, right? And then the contralateral side. How about MBP? MBP also is a contralateral, right? Because in the all left side is affected, right? So how about the corticospinal tract? It's also contralateral sided, right? How about the cranial lobe? Everything, basically, everything is a contralateral side. So, but cranial lobe is not going to be affected, right? Cranial lobe, because it's not affected, only in the if it's in the right side. Left cranial lobe is perfectly fine. All right. So, how about your region is in the cortex? What's going to be affected? So, your the corticospinal tract, contralateral side, and the cranial lobe is not affected, and the spinal thalamic tract in the contralateral, and the also the MBP also contralateral. Okay, so just by knowing this the diagram, drawing the diagram correctly, during the 15 minutes interval, 15 minutes before the the exam start. Just draw this diagram, and then your life will be much easier. Okay. All right. So let's just go back to the where we were. Just where are we? Okay, here. Let me see, where are we? Okay, yeah, here. So I'll give you like say 30 seconds. I'll just highlight the word that is the important. Light touch, position, and vibration, so preserved, and able pinprick and temperature sensation. Okay, by the way, you can just think about there's no such thing as MVP, right? There's no such thing as, oh yeah, vibration was the damaged, but the proper reception was okay. There's basically in practical purpose, in terms of exam, there is no such thing as this. Always MVP go together. Always pain and temperature go together. I mean, theoretically there's a one exception I told you about the anterior, the spinal thalamic tract. That's the only exception, but I don't think they will ask you that kind of detail. That's not good. Okay, so think about pain and temperature. If, for instance, here the pinprick and temperature, right? So it goes together. If they only say temperature, that's fine. Pain and the pain is already, come together. Okay. So if they say the light touch like MVP, right? MVP. So it always go together. Even if they say the vibration, so that's always automatically you just consider the other one too. Okay. So yes, S A is the correct answer. Good, good. So the why what if I say the D instead of drawing D here, if I say drawing D here, the light touch was the I mean the pain and temperature was the problem, right? So what if I say D right here instead of here? Okay, why not D? Can anybody tell why not D? Would you still, if I say D here, would you still say the answer to be A? Yes, 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 yes. Bilateral is the key. Okay. If it's a D, then that will be the unilateral. Okay. Bilateral is the key. Okay. That's the very important point. Okay. All right. Good, good, good. All right. So basically this is a Shringo. Okay. So in Shringo, what happens is this thing is becoming bigger and bigger. Okay, so only one side for D. Yes, good. So syringomyelia is basically this the white commission. I mean the central canal becomes bigger and bigger. Okay, so there's a if you do that, then it will be there's a like a little uh, there's a little thing here. There's a white commissure. White commissure will be affected first because of this. White commissure is basically the pathway to the pain and temperature sensation. It pathway here, and then decussate then goes up. Okay, so the pain and temperature will be affected, but because of this is a kind of this like a dorsal column is kind of the reserved. I mean, of course, toward the end, if it's like a progress is long time, then everything will be messed up. But at the beginning, it will be just maybe it comes in here and here, more not like not like going to the dorsal side. Okay, all right, good, good. Now this one. Oh, by the way, a lot of question be on the multiple sclerosis. Multiple sclerosis, in terms of the they will not ask you about the pharmacological things, or they will not ask you about the pathologies, or the pathologists, probably not, right? But they will ask you about the multiple sclerosis only because multiple sclerosis means demyelination. Okay, multiple sclerosis demyelinating disease, and then if you look at the keyword or the radiology graph, you will see the periventricular calcification. Let me write it here. Multiple sclerosis, periventricular the calcification. That's the keyword. And then demyelination. Those are two things that you need to know. Okay, that's why this is a fair question for you, even if you didn't you didn't learn pathophysiology of the multiple sclerosis. Doesn't matter, because what they are asking is not the pathophysiology. They will ask you what's the problem. You learn that multiple sclerosis is demyelinating disease. That's all you need to know. Okay, so periventricular calcification. Okay, so let me ask you, out of this, if it's the CNS problem, so multiple sclerosis is the CNS problem. Okay, because it's in the brain and plus spinal cord is a CNS, right? So it's the CNS problem. So if it's a CNS problem, is it going to be upper motor neuron affected or the lower motor neuron? Remember, lower motor neuron is different from upper motor neuron in terms of the regions. Okay, so what's what's out of this? Okay, what are the specific for CNS? I mean PNS. Out of this, the A, B, C, D, E. What are the like for only PNS? Yes. Schwann cells, only PNS. So now we are talking about the A, B, C, D. Okay, so this one is like multiple avoid white matter regions. White matter. Okay, what's white matter? Do you think the brain? The neurons have this the axons, and then the white matter. White matter. Already in neurology, white matter means myelination. Myelination is kind of fatty cells, very kind of the covering. Okay, so very covering of this the axons. So it has like a little hole in here in between the fat. Okay, and then only this part will be conducted. So fatty acids is not fatty part. It's just non-conductive. It's kind of almost like when you have the cables, like electric cables, you just cover with the non-conductive covering, right? That covering is a myelination. Okay, so because you cover this area here, cover this area, the action potential will not go out here. It's because it's just basically non-conductive the covering. So your action potential is staying in the inside, so it goes much faster, right? So here, if I draw like this, it goes. There's no other way that it goes out. It cannot go out. It just goes. The action potential goes here very fast. Then it has to continue to go, but it'll always like kind of degenerate, right? So it is supposed to degenerate here. So here is a big action potential, and smaller, and then it's about to degenerate. There's the opening right there, and then it'll jump. That's called saltated conduction. Saltated conduction. Okay. So load of Lambier, right? Lambier. Okay. So load of Namibia is a kind of exchange. I mean, like the how do you call that? Like the when the highways there's like the kind of the toll gate. Yeah, that kind of things. Okay. All right. So out of this, which one has something to do with the myelination? Okay. So what? Let me just explain this thing. What does astrocyte do? Anyone can tell? What's the astrocyte? Yes, that is correct. Yes. What does astrocyte do? Yes. Astrocyte, PBB, and fit. Yes. 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 Good. So all you need to know, astrocyte, PBB. Okay. How about ependymal cells? What does ependymal cells do? Line the central canal. Yes. Choroid plexus. It makes the CSF. It's just basically the CSF. It's made of in the choroidal plexus. Yes, yes. So think about CSF. Microglia cells. Okay, so I think I told you about this. Probably think about, I told you about this. Microglia cells. Let me just write down here. Microglia cells, the macrophages, Kupffer cells, I think Kupffer cells, and then Langerhans cells. What else? All those things and monocyte, they are same thing. Depending on where the macrophages is or monocyte is, they will just change the names. They are basically the same thing. Whenever you see this thing, macrophagy, microglial cells, Langerhans cells, monocyte, when theoretically, when they are in the blood, it will be monocyte. And then when coming out of the blood and then to the tissue, it becomes a macrophages. If it's in the liver, Kupffer cells. If it's in the skin, Langerhans cells. If it's in the brain, macroglial cells. They basically same thing. Okay, so don't get tripped on this. Oh yeah, what is don't basically don't get tripped on this like the different names. Okay, they are in medical literature, everyone wants to have their own names. So Langerhans is the name of the person, name of the doctor that, oh, I want, I find this first, just, I'm going to name it under my name. Oh, I just find the macrophages in the liver. So I'm going to, the name after me. That's all like, they are all kind of, the very, very selfish to name it. Okay. So, but they are basically the same thing. Okay. So oligodendrocyte and then Schwann cells are the one that something to do with the myelination. Okay, so oligodendrocyte in the CNS, then Schwann cells in the PNS. Okay, all right. So the answer to that is oligodendrocyte. Okay, good, good. Now this one. Let me highlight the word that is probably important. Tuberculosis meningitis. Here's TB, and do you know the yes? Why? Can you? Okay, so she is correct. Do you know why? What does the arachidonic granules do? Answer. Your answer is correct, but why though? Because they observe the CSF. So basically, arachidonic granules is a CSF to vein. Because everything in the body has to be circulating. Okay, if it's not circulating, it will stale, and then the dead cells are dead, and then other fluid will be stale, and then eventually go bad, right? So rotten, right? So everything has to be circulated. Even the CSF has to be circulated too, right? So every ventricle, yes. So CSF is circulating, but where does it go? It has to go through go to the veins, right? It goes to the vein, and then new CF S will be generated from the ependymal cells and choroid plexus. Okay, so the circulation key, the drain is this is a kind of drain. Okay, so if the draining problem, then it is called who is amen is correct. So if the drain is not there, drain is like blocked, clogged, then every ventricle will be enlarged. That's correct. That's absolutely that's a good point. Okay, so that's called, how do you call that the condition? CSF, I mean the ventricle will be enlarged. How do you call that condition? Hydrocephalus. Basically, if it's the drain is the drain is like the blocked, so then let me use a different color. If drain was blocked, and then everything the CSF flows will be enlarged. This is enlarged. Everything is enlarged. Yes, that's called communicating hydrocephalus. Okay, basically uh, communicating hydrocephalus is drain problem. Okay, how about non-communicating hydrocephalus? What's the problem here? What does the non-communicating mean? Non-communicating simply means obstruction, right? Something, yes, there is some obstruction that's going to be the non-communicating. In this case, I mean, not this case. Here, this case, drain problem, you can, you can say, oh yeah, that's also obstruction. Yes, true, but we have to kind of distinguish between the drain problem or obstruction problem. So that's why we just name it as the non-communicating. I mean, communicating. Okay, if it's the drain problem, communicating. If it's the something other than draining the veins, that is called non-communicating. Non-communicating means obstructive of the hydrocephalus. Same thing. Okay, so it can depend on where it the blocks. Okay, so the lateral ventricle to third ventricle, and then third ventricle to first ventricle. The Lucica, and then the Magenta, and the Monroe, that kind of things, right? So if the Monroe, I mean, say like the Sylvia, the aqueduct of Sylvia is a brain drain, which is like a first ventricle. After that, it's going to be the Sylvia. If it's the drain, I mean, if it's blocked, then first the ventricle just before that will be the block. It will be enlarged. Okay, so that's the anatomy, right? So you know this one. Okay, all right. This one, also. Uh, this one will be also kind of popular topic. Okay. A lot of questions are from multiple sclerosis. Multiple sclerosis is so popular topic in exam as well as in the clinical. Okay, very important, very important disease. Also very common. Okay, but because you didn't learn the pathophysiology here, you will they will test you when there's like demyelination. Okay. When demyelination, basically, when you have the demyelination, that function is debilitated, right? The function is not there. So it will be just the like multiple. The typical example is when you say multiple sclerosis, you remember this thing: time and space. What I mean, time and space means that it will just random timing. So, and then space means that random spacing. What I mean is that it can happen, you know, anywhere in the CNS. So it will happen. Sometimes it happens in the eye, and then maybe tomorrow I have like some problem with the arms, or maybe another day I have a problem with the liver. I mean the lower leg, and the space is like everywhere. So So it can happen everywhere, but all you need to know, I mean, always very most common location, and the symptoms is going to be optic neuritis. Optic neuritis. Optic neuritis means optic nerve, neuritis. There's some inflammation. Okay, so that's the important thing. Okay, so in this case, optic neuritis happening, demyelination, they are the kind enough to name demyelination. Okay, so optic neuritis means that optic nerve. So optic nerve is the cranial nerve too, right? Optic nerve is like not functioning. What's going to happen? Uh, light reflex. Okay, light reflex. Light reflex. If it's basically you shine the light and the pupil will be the shrinking, right? That's the light reflex. Okay, so pupil size will be the shrinking. So it will just control depending on the adjust the pupil size so that you don't get too much light inside of the eyeball. Okay, so that's what the light reflex is. Okay. So what two cranial lobes involved in the light reflex? There is always cross the any reflex has always have a inbound problem, outbound problem, right? Inbound, what cranial lobe is involved in inbound, and what cranial lobe is involved in the outbound? 2 and 3, yes. In by 2, out by 3. Okay, so uh, okay, let me give you one even further the problem. Two is inbound. In is 2, right? So 3 has the 3 has two functions. Do you know that? Cranial lobe 3 is not just one the knob. It's actually two functional knob. So let me draw it here. Cranial lobe 3 is cranial lobe 3, right? Cranial lobe 3 has it's basically it's like a kind of kind of outer covering. Okay, so if you look at it in the cross section, it will be cranial lobe 3 is like this. There are two functions: motor function, and then also the parasympathetic function. Which one is in the center? Motor function or parasympathetic function? Motor is in the center. Yes, that's absolutely correct. So motor, parasympathetic. So now let me this is an important question. This may be in the exam. Okay. So this is a neuron, right? Not the like blood vessel. Okay. So there's a blood vessel just supplying this the nerve, right? Every tissue or every nerve has a blood vessel supplying it, right? So blood vessel supplies. Does blood vessel supply from inside to out? No, it's blood vessel supposed to supply from, it's outside of the neuron. Neuron is a kind of structure, tissue. You cannot have inside of, there's nothing inside, no blood inside. So blood vessel is supposed to be outside of the neuron, right? So this is a blood vessel, and that supplies the neuron. Okay. So let me write it. Let me draw it this way. Okay. So if the blood, there's some the lack of blood supply is not kind of enough. Which part of the cranial of 3 will be damaged first? This is an important question. Very important question. Not only this one, this particular example, but this will apply all kind of the all kind of the function, all kind of the pathophysiologists. If the blood supply is not there, like for instance, ischemic, okay, ischemia, motor is damaged first. Why? Can you tell me why? Your answer is correct. Why? Don't just memorize it. I think you know the answer, but the why? Can you explain why? You can, if you don't want to write it down, you can just the unmute and talk. This is a very, very important concept. Okay. The blood is coming from here, right? So this is like motor part, right? This is motor part, and then this is the parasympathetic part, right? So which is the farthest from the blood supply? If enough blood is there, then you can just go all the way to the motor, no problem, right? But if blood is lack of blood, so only small amount of, I mean, very little blood is the supplying here, then you cannot have all the way. The blood will be just say I mean say 100 milligrams goes here, supposed to be. But you now have like a 30 milligrams. I mean, I'm just making up the numbers, okay? 30 milligrams only goes only here, right? So, but still enough, only enough for supplying parasympathetic portion of the cranial artery, but not good enough to supply the further, because the motor part of the cranial artery is further away from the blood supply. You agree? That's why motor is damaged first. Okay, so that's the scenario one. Now, another scenario. If there's like some blockages, I mean, so not the blockage. It's if there's some compression, say some tumor growing here, tumor. Oh my God, my handwriting is like, problem with my handwriting is I cannot read my own handwriting. Tumor, okay? So tumor is here. Which one will be damaged first? Parasympathetic or motor? Which one is damaged first? Yes. Why? Because it's, yeah, just tumor is just compressing the outside, which is like close, tumor is right here, tumor. Then it will just parasympathetic is damaged. Okay? Outermost. Yes, that's correct. Absolutely correct. Knowing this concept is very, very, very important. Okay? It will be on the exam for sure. Can you explain how diabetic neuroretinopathy affects this too? Yes. Diabetes. Think about diabetes, non-enzymatic glycosylation. Non-enzymatic glycosylation simply means sugar damage. Sugar damage simply means sugar is always kind of sticky, right? Sticky damage. Okay. What I mean is that this one. Let me draw in here. This is a blood vessel. So blood vessel has like endothelial cells, right? Endothelial cells, right? Here, right? So blood vessel here. So now sugar is glucose, right? Glucose is here, right? Many sugar particles in there. Sugar is always sticky. Sticky is the problem. If it's a sticky, normally insulin is there, and then insulin brings the sugar into the cell if there's a high sugar, right? So that's a normal process. But so not, so insulin kind of controls the amount of sugar in the sugar particles, sugar molecules in the blood vessel. That's what the insulin is supposed to do. Diabetes don't have that kind of functions. Either the receptor problem or insulin is not there. Whatever the condition is, sugar molecules cannot come into the cell, and they cannot make the ATP energy. Okay, so the reason that diabetes is called wasting disease is that sugar, you have a lot of sugar. If you measure the blood vessel, and then if you just draw the blood, and then see the if there's any sugar, there are tons of sugar. Okay, glucose is very high, but problem is that glucose cannot be utilized It has to be, to be utilized in the cell, there has to be, the glucose has to be coming to the cell, endothelial cell, and then other part of the cells that makes the energy. But this is not there. So glucose is a lot of sugar particles. Sugar is sticky. So it will deposit here, sticky. It's a covering sugar molecule here, sugar molecule here, sugar molecule here, more sugar. It will be sticky. So it will cover the endothelial cells. So can blood go easily? No, because it's sticky, and then the diameter becomes narrow. So blood cannot go through. The red blood cell cannot go through. So you have in the eye there are many small in the retina there's a, because the retina is very bloody, meaning that there are many small the capillaries, right? So small capillaries, in the small capillaries, many small capillaries have is blocked because of the capillaries are all the surface of the endothelial cell here is covered with the sugar. So blood cannot go through, and then ischemic damages. Okay, so that's what the diabetic retinopathy. Okay, all right. So hopefully that's clear. All right. So by the way, so back to this question. So basically here is a cranial lobe 2 is the problem, right? Cranial lobe 2, which is just the in part of the this light reflex, right? So our part is okay, but 2 is a problem, right? So the 2 is the problem. So if you are no input, then output cannot happen, right? So this will be the right people is the right side problem, right? Right side optic nerve is problem. Right side of the cranial 2 is a problem. Right side of input problem. So input is not there. Of course, if there's no input, no stimulation, no the output, right? So this will be absent, right? I mean, in this particular question, this already give away because it's absent. Absent is only one choices. So this A has to be answer. But okay, but this side. So this side is okay. If it's shine on the left side, then input. So left side was no problem. So input output no problem. How about the right side? Right side, it will constrict based on cranial lobe 3, not cranial lobe 2, right? So cranial lobe 3 was okay. So that's why this is normal, all right? Hopefully you understand this. So another question is, okay, that what portion of the cranial lobe 3 was the problem? Is it motor part of the cranial lobe 3 or parasympathetic part of the cranial lobe 3? What makes this normal? What part of the cranial the 3 was working so that the right pupil will be constructed when shine on the left side? Is it parasympathetic, the portion of the cranial 3, or yes, because of motor part, ocular motor, ocular motor, right? Ocular motor. Only like the 3 ocular motors. So um how to call it, like the medial vectors and all those things, right? All other things other than the SO4 LR6, right? LR6. Other than this, lateral rectus muscle and then other superior oblicular muscles. Other than this, all 3, right? So cranial 3 for motor part is this one. And then constrictor the pupils, that's parasympathetic. Okay, all right. Hopefully the answer is A too. Okay, so this one. Okay, this one maybe a little bit. I'm not sure that you learned this one. this is why is the answer absent for the left pupil constriction? Okay, so left side, you mean the this one, right? You're talking about this one, right? So why is the answer absent for the left pupil constriction? Okay, so here left, so input is a 2, and then out part is a 3, right? So input is not there. If the stimulation is not there, then how can you the react? Your input is not there, then the left side, right side, you shine on the right side. Yes, so right side input is not there, then 3 will not do anything. I mean the left side will not do anything because the no stimulation, no reaction. Okay. All right. So I'm not sure whether you learned this, but did you learn this kind of the concept? The puns. When the sodium level is too high or too little, then if you correct it, I don't believe so. Okay. If you basically this is like because I picked this question because it's the demyelination problem. Probably you not have these questions. So this is the osmotic demyelination syndrome. What happens is that too much of the too little sodium. Then you want to correct it. So basically, you kind of give some drugs or some sodium, so increase the sodium level too quickly. Then it will. Whenever you see the sodium, you think about the osmosis. Okay, so you change the osmosis too quickly. So then that's the problem. So there are too little the sodium is correcting. So you wanna increase the sodium, right? Increase the sodium. You wanna increase the sodium too quickly. Then it will cause this osmotic demyelinating syndrome. Okay. On the other hand, if it's a too high sodium, if you decrease the sodium too quickly, so by giving some water or something like that, then you will have a edema. Okay, the cerebral edema, or this is called the cerebral pontine demyelination syndrome, which will usually occur in the cerebral. The reason that they cerebral pontine is that the location usually happens in the cerebral pontine area. Okay, cerebellum and pontine area. So that's why it's the cerebral pontine demyelination syndrome. Okay, all right. So this one is a good distinguishing point between uh, some other some other symptom than this one. Okay, let me just highlight the word that's the important. Decrease the right letter form. What do you think? The question. You learned the MSK, right? You learned muscular, right? So this is, I think, this is a good integration question. I highlight the uh, I highlight the word that is important. Okay, what do you think the answer to this question? Any guess? G? Yeah, G is correct. Okay. So actually I got it wrong. at the first, because I didn't even too much pay attention to it, because when I read this, I didn't read it like in detail, and then it's a problem with the weekend, and then now we are learning the neuro, and this must be like the shingo. That's what I first thought. That this was if that's why I highlighted right. Okay, so if this was like a bilateral, then you will think about the shringo. Then it will be cystic dilation, cystic expansion, right? Cystic simply means that there's a kind of expanding the spinal, cerebral spinal fluid. So cystic means like the this thing here. This is the central canal, right? Central canal. And then what's inside of the central canal? That's the CSF, right? CSF expand, then it will become like big, right? Oh, where is big, right? It will become expand, right? So that's the cystic dilation. That's going to shringo idea. Okay. So, but now that will happen bilaterally, but here it's only unilateral. So this is not shringo is not the answer. Okay. All right. This one is important because this one the in first aid. I think first aid. Let me open the first aid while you are doing this. Let me open the first aid. First aid is in the. mm, yeah, urology and neurology and H and urology. Okay, so mm, yeah, this one right there. This one you need to know. It's a page in my version, which is a 2023 version. It's a page 546 in first aid. You need to know this one. Okay. So the myelitis. Sorry, polio. Polio. Okay, polio is a anterior horn. So that's one. The high keyword here is low motor neuron, anterior asymmetric, and then that's why they call it. They just make it big and then small. Okay, asymmetric. So anterior horn. Okay, and then spinal muscular dystrophy. This is the congenital condition, and then low motor neuron only. Okay, so that's the fluffy baby. That's what you need to know. And then ALS so the lower motor neuron and also upper motor neuron, both. Okay, so here is a spastic. So whenever the upper motor neuron has a spastic, okay. So this is another name for that. This is a Lou Gehrig disease. Okay, so you have to know both names: ALS, Lou Gehrig. Lou Gehrig. The who is Lou Gehrig? Anyone know who is Lou Gehrig? It's a Yankees baseball player. Okay. I think isn't Lou Gehrig, did Lou Gehrig married to Marilyn Monroe? No, right? No, that's different person. Okay, Lou Gehrig, I think he set some kind of a record for the Hall of Fame or something like that. Okay, so anyway, so Lou Gehrig, is the generic concern. Okay, Tavis dorsalis, big the important topic. Only in the dorsal column only. Okay. Dorsal column only, and then the radial Robertson pupil, and then the Lomborg sign and all these things. Okay, so you need to know this. And then subocular combined degeneration. This is what the question was. This is the basically tabes dorsalis plus the spinal thalamic tract. The cerebellar tract. Say. Okay, all right. So that's something you need to know, right? So corticospinal tract and then the dorsal column. Corticospinal tract, yeah, corticospinal tract, and then dorsal column. You need to know that. And then anterior spinal artery occlusion. I told you about the anterior spinal artery and then posterior spinal artery, right? So posterior, basically, the different, although this is one and then this is two, it covers more regions. It's because of the anterior spinal artery has a more blood. It's a larger diameter. Yes, true. But also another thing is that this one comes from the basal artery and the bottom, sorry, pica, and then it goes to the anterior spinal artery. Also, some part from the basal artery, but this one also from pica and then basal artery too. But this one is not, it's kind of, it's too detailed, but it's kind of not continuously the supplied. Okay, so it will be it's like this. The posterior spinal artery is kind of supply here, and then discontinue, and then supply here, and then discontinue. It's kind of like this. So this dorsal column usually is the first more prone to ischemic damages, or more prone to whenever there's a ischemic damages, there's some the like higher chance to get infection too. Okay, so more prone to damage it. Okay. All right. So anyway, so this page is very, very important. Just to know the keyword. Okay. So ASA damages this part, and then this is basically the B12 deficient. Okay, B12 deficient. Then this is B12. B12. Okay, B12 damages corticospinal tract plus the dorsal column, and then Davis dorsalis syphilis, tertiary syphilis. Okay, and then the ALS. This the upper motor neuron and lower motor neuron, right? So spinal muscular atrophy is the flappy baby, and then polio, anterior horn. Okay, something you need to know. All right. So let's go back to the questions here. All right. So here, he has a where is it? Let me highlight the word that is the occult blood, the bit negative, and then the palmacris, the shiny tongue and palmacris. Okay, so shiny tongue and then pale palmacris. So what does it mean without even knowing anything? Okay, say if you know only this thing, pale. Whenever you see pale, anemia. Okay, pale anemia, right? So one step further, whether it's there are different types of anemias, right? So gastrectomy, what does that mean? If there's if you cut down, if you like cut out the stomach, then what's going to happen? So gastrectomy, depending on which part you cut out, but most of the time, if the question is not specify which part, you can just assume the B12 deficiency, gastrectomy, B12 deficiency, because of the intrinsic factor. Okay, so that will cause megaloblastic anemia. Megaloblastic anemia simply means B12 or B9 folate. Okay, so if B12 deficient, then this thing right there, subacute combined degeneration. So you will have the dorsal column plus corticospinal tract. Okay, so subacute combined degeneration, it will cause dorsal column and this one, and then dorsal column and then corticospinal tract here. Okay, so D is the answer, right? Okay, so this one. Let me just highlight the word. Intelligent vision performed medical control. If you already done MSK, right? Do you know what's the in what conditions each tube is contraindicated? Just for the side, just kind of for extra point. I think you learned this in the MSK. In which MSK conditions that ET tube, endotracheal intubation is contraindicated? Do you know? Okay, so answer these questions first. What do you think? This is a kind of integrated question with MSK and the neuro. I think this is a very good question because if I am a professor, I would highly rate these questions. But this will be kind of, hard questions, not easy questions. In terms of like difficulty level, one to say 1 through 5 is the difficulty level. This is kind of, the 4. Okay. What will be my hint is like urgent endotracheal intubation, right? ET tube. In what conditions is contraindicated? Anyone answers? Anyone? Any guesses on this question? Do you know instability, Atlanto axial instability? The C1 through C7, right? So C1 through C2, that is a AA. Okay, Atlanto axial. So it's kind of Atlanto axial means like kind of in the Greek mythology that Atlas is kind of the supporting the Earth. This is Earth. Earth is kind of round, right? So supporting it. So that's why it's called Atlantis, right? So Atlantis is supporting this thing like this. Okay. So that area is a very vulnerable for if that is unstable, what's going to happen? If that is unstable, and if you do in that condition, if you do the intubation, endotracheal tube, so endotracheal tube will be just insert. It's kind of looks like this. If you insert it like forcefully, it will damage some the nerves here. Okay, if that's damaged, you are done. Basically, you kill the patient. Very you have to be very careful for doing endotracheal the intubation. Okay, so another question is that in which congenital conditions atlantoaxial instability occurs? In which conditions? Let me just give you a hint. It's kind of the trisomy. Trisomy. So which trisomy will be will have a like high incidence of atlantoaxial instability. Do you know? Down 21 trisomy. Okay, so this is a actually integrated questions, and because with the MSK and also maybe other respiratory too. But so this is a very kind of this is a kind of question you will expect in step 1 real exam. Okay. So this is the answer to that is the vertebral subluxation. So if there's an atlantoaxial instability, if you forcefully try to intubate it, then that will damage the nerve, and then the patient is done. Done means gone, it's dead or paralyzed, flaccid paralysis. Okay. So this is a bit. I'll give you all these the answers, so you can just read it later, right? Important. Okay, so the rheumatoid arthritis and any other conditions, actually any other conditions that cervical spine is like a in this particular case, rheumatoid arthritis cases, so basically your spine is not like a straight. Basically, the old part of it can happen anywhere, right? In the rheumatoid RA can happen anywhere. Your spine is not straight. It's not like it's kind of because of the structural problems. It will cause the structural problems. And one of the cause can be the cervical spine is not straight. And then, so atlantoaxial spine, the joint is not stable. All right. Let me see. So these questions. Begin to the introduction. Actually, this one is again, this is the same question as the previous. It's like if the you are talking about the SI ADH, and the SIDH means that B the cerebral demerge. Yes, exactly right. Okay. So if it the decrease or the correct it too quickly, that's the problem. Okay, good. All right. This one. It's normal. Slow and impaired adduction. The left eye with the right lateral gaze. And then age is important. Acute onset diplopia. Okay, what do you think? What do you think of the optic disc atrophy? So what do you think this she has? We discussed this like many already few questions about the same conditions. Multiple sclerosis. Multiple sclerosis, multiple, so many. Sclerosis means kind of hardening. Okay, hardening means like a calcification. Okay, so I think there's a picture somewhere. I'll show you the picture somewhere. Okay, so let me just, why don't I just picture show the picture. Multiple MS, the ready, MS radiology. Very unique, the picture that you need to know, right? This is like this, if they show if they are kind enough, to show you the this radiology picture, you should be thankful. It just shows this is the MS. So meaning that this side is the periventricular calcification. This the white part, the periventricular, just next, like surrounding the ventricle, is calcified. This is a typical example. Okay, so MS, just periventricular calcification. That's just a just giveaway. All right. All right. So let's just go to by the way, so so this is MS question. Okay, MS. So if it's a demyelination, right? MS means the demyelination, right? Demyelination. If demyelination, then what's the problem? If myelin is like this, right? This is myelination. If demyelination, this was like a gun, this is gone, then what's going to happen? What will be impacted? What does myelination will do? Myelination, if you if you have a myelin, which is kind of fat material covering the conduction here, then what kind of conduction would you have? If it was myelinated, then what kind of conduction will you have? So because of the action potential cannot come out here, right? Cannot come out. So it will come out only in here, then jump, jump. So what kind of saltated conduction? Yes. So reduced saltated conduction. Okay. So that's the answer. So the way that recognize this one is multiple sclerosis, young female. Okay, young female, acute onset, and there are some problem, some time ago, and then 6 months and 2 months ago, right? So time different, right? And then also sometimes they will say the problem with the like weakened the lower extremities and that kind of things. They will say that too. Okay, so that's one of the problem. Okay, so time and space. So space means that it can happen anywhere in the body. All right. All right. So chronic white matter changes with no infection. So let me just highlight the word that is the important. Diffuse ventriculomegaly with no circle enlargement. So she has incontinence, and then also forgetful, and then the inability to walk. What do you think? You learned this, right? What kind of the condition does she have? And old people. This is like very picture perfect. Picture perfect of what kind of symptoms are we talking about? You need to know this. Anyone know what kind of symptoms we're talking about? Do you know WWW? Does it ring the bell? No, not yet. Normal pressure, the hydrocephalus. Hydrocephalus. I mean, and normal pressure hydrocephalus. Okay, so normal pressure hydrocephalus simply means it's because of the draining problem. So this is like theoretically this is like basically same as the communicating hydrocephalus. Okay, it's a type of communicating hydrocephalus. Okay, so if it's draining problem, so then it will be your ventricle will be enlarged, right? So if the ventricle is enlarged, what's the main problem? if the ventricle is enlarged, for young people, it's not really a big problem because the young people, is the neuron is not well developed yet. So the young kid, I mean, the young kid means like infant or like maybe very, very baby. Okay, babies, it's not a big problem, but like adult, if the cerebral spinal fluid is like edema, like big, the ventricle becomes big, then what's the problem? Main problem. Main problem is it will becomes big. The skull, like this is a skull, right? Skull is covered with like I mean brain is covered with the skull, right? Skull is you cannot expand the skull, right? So brain has a like limited space, very limited space. Now then, if there's a some like your the ventricle is enlarged, in other words, the a lot of space is occupied by the cerebral spinal fluid, then your other structures will be compressed, right? So what will be compressed? It will be uh, it will be like some the neurons are here, neurons goes here. That neurons will be stretched and compressed, right? That's the problem. So one of the problem is because of the if the corticospinal tract is the compressed, you will have the walk problem. If the corticospinal tract that controls the urine, so it like all the way like maybe the L2, L3, L4, or that kind of area, then it will cause the incontinence. And then if that stretches the frontal area, executive function, then that will cause the dementia. So that's why it's a wet, wet, wobbly, wacky, wobbly, wet, whatever. Okay. So that's why it's a normal pressure hydrocephalus occurs. That's the main thing. So main cause of this the normal pressure hydrocephalus is that because of the stretching the neurons. Okay. So the E stands there, right? So you need to know the like kind of the wide cause is that. Okay. So by just looking at this, you can it's a very hard to tell uh, to distinguish with this and the other things because when you, by just looking at it, that can be the draining problem. That can be even non-communicating the hydrocephalus too. It has a very similar the feature, very similar to radiology. So you have to look at the questions, histories. Okay. All right. So let's do this one question. This one is a, you should know this one question. So let me just highlight the word. Low back pain versus back flexion, and then the radiating pinprick to perianal area does not cause the rapid contraction of the anal sphincter. So anal sphincter. Okay, what do you think? What are the dermatome causing anal sphincter problem? Anal area, anal area. What's the? Do you know the wink reflex? We we usually don't do this in physical exams, but wink reflex simply means that you put the fingers in the anus, and then if the anus is like the contracting, I mean, like they contract the muscles, the anal muscles. Okay, so that's called wink reflex. If it doesn't, then means oh, you have a problem. So my question is, what the dermatome, the wink reflex, the anus, the occurs? Do you know? Anyone know? So that's SO4, okay? So one of the dermatome that the I will tell you one of the dermatome here, somewhere here. Let me see. Hopefully, I can find that easily. Oh yeah, maybe it's in the beginning. Okay, right. It's in the right, right there. Okay, so this is a dermatom. Okay, this is dermatom, and very very complicated to the realize. Try to memorize this one. Very very hard, right? So though, why is it so kind of wiggly? Instead of just everything. I mean, sorry, not this. If the everything is like a straight line, horizontal, or this is like a straight line, it'll be easier. But now it's like it's a kind of it's going this way, like this way, and then this way. It's just very complicated, and then even circling like this. Why is it so difficult to memorize, right? So if we look at this in the this position, because when we were in maybe long time ago, we were not like animals, right? Animals is going crawling like this form, right? This position, right? So if then it will be everything is straight line. Okay, so just mapping. Just image when you look at this the tomatoes, think about like when you are like a crawling position, okay? Then everything will be straight line. So when you crawl, this will be the here will be here, straight line here. I mean the vertical lines, okay? So the think about this, okay? All right. So S4, and then okay, so maybe we have like two more questions and we'll be done. Okay. Welling during optic disc on the left. Intention tremor and the broad-based gait. 32-year-old woman. After hot shower. Okay. This is a key point actually. Anyone can tell what it is? Anyone, any idea? Again, this is multiple sclerosis. Young woman, the walls with hot weather. And another big thing is the electrifying sensation. Electrifying sensation. It's called the limit sign. Limit, I think. Okay. The LE, the limit, L limit sign. Okay. This electrical the sensation. And then also another thing is that the hot weather makes it worse. That's called like the the syndrome, Orthof sign. So when you go in the hot weather, it makes it worse. Okay. So again, this is a demyelination plug. The see why? Because I picked the questions from the U world. That is physiology. So this is not med 3, med 4 stuff. It's more kind of med 1 stuff. Okay, and these questions come up. So they ask the MS questions so many times because it's so important. All right. Let's do two more questions, and we are done. Okay. Use mononucleoside and oligoclonal bending. This is say okay. So let me just this question. This question is really kind of the difficult question. I guessed. I just guessed in for the oligodendrocyte depletion, but oligoclonal bending and this was like I think this is like a kind of if they ask this kind of questions, it will be a little unfair to me. Yeah. So but the answer to that is like oligoclonal bending. That's the question, okay? All right. Maybe this is a last question, I think. All right. Uh, Bilateral specificity. So, specificity, what do you mean? Specific. the upper motor neuron sign, lower motor neuron sign, right? Whenever you see spasticity, is it the upper motor neuron or lower motor neuron? By just picking up this word, you just have like half right already. Is it upper motor neuron spasticity or the lower motor neuron? Upper motor neuron, yes. Lower motor neuron is flaccid paralysis. Upper motor neuron, spastic paralysis. Basically, upper motor neuron, the reason is that the upper motor neuron is like your central nervous system will kind of basically they don't care about the you raising hand or lower hand. What they care is like, okay, go or not go. That's only two things. Then lower motor neuron will kind of upper motor neuron is a kind of commander, and then this is kind of actor. It will kind of adjust. Okay, so you are just making it go. Okay, so I will make it kind of adjust the speed or and then the strength. That kind of things will be done in lower motor neuron. So if upper motor neuron is damaged, you will have like it's either the go or not go only. So very, very crude the movement. So that will cause like spasticity. Okay. So the this one mild bilateral is also important. Okay. So this is like also again, I'm sorry to tell you, but many questions are the multiple sclerosis, but their conclusion is very, very easy because basically this one multiple sclerosis, all you need to know is demyelination. Okay, and then also upper motor neuron signs. Okay, because it's the CNS. Okay. Lower motor neuron is PNS. Upper motor neuron is CNS. Okay, so the upper motor neuron spasticity. Okay, that's all you need to know. All right, so it's a calcification. Basically, calcification simply means the periventricular. The calcification simply means like inflammatory cells. Okay, all right. There, I think that's it. Okay, all right. So I will stop here. And so your exam was on the Wednesday, right? Okay, so uh, so if you have any questions on this the blog, you can just email me. You know my email address, right? So I will upload this the recording, and then also the annotated version. Why don't I just do that? Annotated version in the chat too, and then also I will upload in the recording in the in my YouTube channel as well. So just the click like and then subscribe to my channel. Okay. All right. So best of luck for your the last case, and then you will you already come you're almost done with the semester. That's a really good thing. And then you're after this year two. I mean the Med 2 is I'll tell you Med 2 is a really good semester. Okay, you will have a good time to adjust to the environment, and then Med 2 is a really from Med 1 through Med 4. I'm Med 5 right now. I just finished Med 4, and then Med 2 was the probably the kind of easiest semester. Okay, Med 1 was hard. Med 3 is very hard. Med 2 is like a kind of you know kind of easy semester. All right. So it's a good time is ahead of you. All right. So I hope you all aced the exam last case. Then you're almost done. All right. So you all got this. All right. Okay. Thank you very much. Okay. I will stop the recording here.